Okay, well, good morning, everybody. I think we're going to get combined rounds started now, just in the interest of time, so hopefully we can provide some questions to Professor Knauf, as well as allow people to get to clinics at 9. So it's a great opportunity for us to have Professor Knauf speak in Canada. This is actually his first time visiting. He's trained extensively in hematology, oncology, and actually in transfusion medicine as well, and had a PhD work that was done looking at risk factor evaluation and cytogenetics in CLL, so I think quite relevant to what we're going to talk to today. Currently, he is based in Frankfurt, as you can see, and was elected co-chair of a committee looking at a union of community center hematologists in Germany. So many of you will know him from his work in CLL, and particularly one of the pivotal studies evaluating bendamustine in the frontline therapy of CLL. In his talk today, we'll look at experience and evidence guiding optimal therapy in the frontline therapy of CLL. So, thank you.
Thank you very much, Dr. Kruvula. Dear colleagues, it makes me intense pleasure to be here. It's, as you mentioned, my first time in Canada, and very first time at Princess Margaret. So I hope that I can share with you in the next couple of minutes some new thoughts on how to treat chronic lymphocytic leukemia. First, due to regulatory issues, this standard disclaimer, and there might be some information on drugs and drugs combinations that are not covered by the current approval status in Canada. And I have, of course, some disclosures to make for honoraria, travel expenses, and advisory board meetings from several pharmaceutical companies. What is the aim of this presentation? I want to share with you the latest scientific evidence and experience-based reasoning in addition for optimal first-line treatment in CLL. So I want to focus really on the treatment-naive patient with CLL who is in need for therapy. And in this context, I want to discuss with you how to characterize chronic lymphocytic leukemia patients according to their fitness and their comorbidity status, because this is then to stratify for different and particular treatments. So the questions to ponder at the moment is it time for all these novel therapies in frontline setting? Do we still need the traditional chemoimmunotherapy? And to begin with, I want to show you this case report from my own center in Frankfurt. This male patient presented first in 2012. At that time, he was 62 years old. We diagnosed chronic lymphocytic leukemia, but in an early stage of disease without any need for treatment. Within then 2.5 years, he progressed into BNA stage C as defined by anemia, hyperleukocytosis, bulky lymph nodes, splenomegaly. So he was then in need for treatment. We did karyotyping and found that this CLL was characterized by deletion 70p and a mutation in the TP53 region as well. But this patient has a lot of comorbidities that made the decision how to treat him a bit complicated. As you can see here, it's a typical vascular patient with coronary heart disease, diabetes, an implant in his arterial femoralis, left side. He had also a mixed restrictive and obstructive lung disorder, and he was under anticoagulation, vitamin K antagonist. So, but he was in urgent need to be treated, and we decided first for some kind of debulking because of this hyperleukocytosis. And we treated him with 2 cycles rituximab plus bendamustine. And you can see here a nice decline in the leukocytes, hemoglobin rose, platelet count rose, lymph node size was shrinking, spleen was a little bit shrinking. And then we switched to idelalisib plus rituximab according to the approval status in the deletion 70p CLL patients. And further on, you can see that the blood count finally was nearly normalized with only 11,000 leukocytes per microliter, normalized hemoglobin, normalized platelets. However, still 70% of these lymphocytes have these 70p deleted. So there is not really a complete response. I would characterize this patient as a good partial response. But then he presented with cough and dyspnea and showed these wide lungs, and we had the typical pneumonitis while on idelalisib, and this is the CT scan of this patient. Very dramatic injury to his lungs. So another experience with IDELA was presented last year at ASH from the Lamson group. And this was a phase 2 trial looking on the usage of idelalisib in frontline treatment. Firstly, idelalisib as a single drug, then it was planned to combine it with ofatumumab in different schedules over time. And interestingly, the group presented not the efficacy results of this trial, but they focused just on the side effects. You are, I guess, familiar with this presentation. At ASH, they showed a high number of patients experiencing hepatitis or transaminitis, they called it, as well as enterocolitis and pneumonitis. And they stated there might be a trend for these side effects in younger patients and patients with a higher lymphocyte count. So to summarize at this point, we had to be cautious when we are using one of these new drugs like idelalisib in frontline setting. And meanwhile, the European Medical Agency has stopped first-line recruitment for idelalisib. And we had to be cautious also with all these other new types of drugs. You are familiar with the usage of obinutuzumab. You know these first cycle infusion-related reactions that can be very, very strong to some patients. We had the warnings with Ibrutinib regarding the atrial fibrillation and the bleeding risk. We had concerns about tumor lysis syndrome, especially with the venetoclax, which is to come in the next few months. So there are some so-called expert panels, and I say, to summarize all these recommendations, that is careful patient selection, prophylaxis against pneumocystis jirovecii, and also CMV screening and monitoring, as well as hepatitis screening and monitoring, is strongly recommended. So all these new drugs may have some difficulties, and at the moment they are mainly for second line or even third line patients to be considered. But I mentioned already the obinutuzumab. This drug is approved in conjunction with Chlorambucil and had shown quite impressive results. What is then the role, for example, for a classical immunochemo like bendamustine rituximab? Just to give you a short reminder on this study, the CLL-11 trial, comparing obinutuzumab plus Chlorambucil with rituximab plus Chlorambucil, and you can see here this shift for longer progression-free survival, while on obinutuzumab the gain is about 10 months with a progression-free survival median one of 26.7. But this is a current update published at the end of last year in Leukemia. There is still no difference in overall survival. So depending on your aim to treat the patient, are you looking for progression-free survival or are you looking on overall survival? Regarding overall survival, there's still no difference. So chlorambucil plus rituximab may still be an option instead of the presence of obinutuzumab. And how does this compares to the more intense chemo, you may say, with bendamustine-based in combination with rituximab? And this was the MaBLe trial, also an internationally conducted trial. Not easy to understand because there were 2 protocol amendments while the protocol was still running. They included then BNA stage A patients and they excluded second-line patients, while in each of the 2 arms already approximately 50 patients at second line has been included. But for the safety analysis, then first and second line patients were combined. And there is another speciality in this protocol because rituximab chlorambucil was given for 6 months, and every patient who had not received then a so-called complete response was scheduled to receive chlorambucil single drug treatment further on for another 6 months. So a schedule which is unusual, I want to say. So this is Efficacy, and I broke down it only to the first-line patients, and you can see here the median progression-free survival, rituximab chlorambucil quite nicely, 30 months, but 40 months with bendamustine plus rituximab, with a complete response rate of 24%. And the median overall survival, 44 months. So the difference regarding complete response and median progression-free survival is statistically in favor to bendamustine rituximab. And this is a patient population which you may say is less fit, because this patient population was scheduled as a standard treatment with chlorambucil rituximab. Other safety data, I just want to focus on the discontinuation. You see here no difference. 19% of the patients discontinued with bendamustine overall, while 18% of all patients discontinued with chlorambucil. So this is another hint to say, okay, it's equally tolerated, even in this less fit patient population. Now coming to the so-called fit patients, you are aware about this CLL 10 trial of the German study group, but it's not only a German trial, there are many, many other European countries involved as well. You know this schedule FCR prospectively randomized against BR. But I want to lay stress on the fact what selection of patients may cause for trial results. Please have a look on the median age in this trial. It's just 61 years. So I ask the perhaps provocative question, are the results of this trial really representative for our daily practice when handling with patients with CLL? Median age at diagnosis is 72. Median age at initiation of first-line treatment is 74. And the median age in this trial is 61. Why is it so? I mean, this is the SEER score and its kidney function. So you can see that only 21%, approximately 1/5 of the patient within this trial, was aged over 65. And in addition, and I'm sure you heard Barbara Eichhorst on this topic already, there was a bias, despite of the computed randomization, that in the BR arm were more patients at an older age stage, and there were more patients with a unmutated EGFR. So you know these curves. The younger patients, younger than 65, showed a longer progression-free survival while treated with FCR, but the patients above the age of 65 showed no difference statistically regarding progression-free survival. And of major interest, there is so far no difference in overall survival when looking on the whole group. So despite the fact that FCR is able to induce a higher amount of complete responses, even at the molecular level, this does not translate, at least so far, in a prolonged overall survival. What about safety and tolerability? I mean, you are aware with hematological toxicities, this is not really a problem to experienced hematologists, but I want to lay stress on the fact that there are secondary neoplasms documented within a quite short time of observation. And there seems to be a trend that more secondary neoplasms may occur in the FCR pretreated patients. And this is in line with a prior observation presented 4 years ago at ASH, never fully published as yet, as far as I know. It's data from the CLL8 trial comparing FCR versus FC. 800 patients included, and with a median time of less than 2 years, 122 patients experienced a secondary cancer. So this is surprising. And in these 122 patients, there were 136 malignant disorders diagnosed, a quite high percentage of solid tumors, but also, as expected, myelodysplasia. And we know the linkage between fludarabine treatment and the damage to bone marrow function, leading to myelodysplastic syndromes, or even then to avert acute myeloid leukemia. So this is also a concern on the long time run when offering a patient, for example, FCR treatment. Another issue was in the CLL10 trial, the safety with respect to infections. The protocol did not prescribe prophylactic antibiotic treatment, but I think it's nowadays consensus internationally. When you are treating a patient with FCR, you are giving him prophylactically, for example, cotrimoxazole, or I don't know your standard operation procedures here, to prevent especially lung infections. And the infection rate was quite higher with the FCR treatment as compared to BR. So in summary, BR in this evidence-based scientific trial was BR is as effective as FCR with respect to overall survival. There might be the subgroup of the younger patients that have profit from a longer progression-free survival with FCR, but there are concerns on long-time effects with FCR, secondary cancers, and there is a higher infectious risk. So this is evidence-based medicine, but what about daily experience? And we installed in Germany a registry in which numerous patients, now more than 4,000 are included, with different malignant lymphoid disorders, including myeloma, including high and low-grade non-Hodgkin's, and of course, chronic lymphocytic leukemia. And we closed the CLL part of this registry already, and we had the chance to look on this patients 348 treated with BR and to compare these to the FCR-treated 137 patients. And as you can see here, that the mean age is quite higher with in the patients treated with BR. So this is not a randomized procedure. The decision to treat a patient with BR or FCR or whatsoever is upon the discretion of the physician. But the data are monitored and collected prospectively, and this is now the, let me say, historical comparison between these two types of treatment. And when we had then a look on the progression-free survival and did an age adjustment, we saw no difference between the BR and the FCR-treated patients, as well as there was no difference in overall survival. So our daily experience, as mirrored by these registry data, confirm the data obtained from the CLL10 trial with respect to the patient group above the age of 65. So where we are standing now, I mean, I think you know this picture, maybe often shown in different presentations. I had some update done with the numbers here, progression-free survival and toxicity ranking. We had to balance between toxicity and efficacy. We see on the left-hand side with the highest efficacy, at least in the younger patients, the FDR regimen. However, with the highest incidence of toxicities, BR, not so bad, 40 to 45 months progression-free survival. We had the Chlorambucil obinutuzumab data. And as you can see here, that regarding toxicity as well as progression-free survival, BR compares favorably with Chlorambucil plus obinutuzumab, while there is no head-to-head comparison as yet. But as I showed you, that the BR zone is also applicable to the less fit patient and turned out to be more efficacious than Chlorambucil plus rituximab, as shown in the MaBLe trial. So the question now, if we consider BR as some standard option for the fit or less fit patient above the age of 65, how to improve on BR? Should we substitute rituximab with obinutuzumab, or should we add something totally new? And this, at the final end, led to the GREEN trial, and I heard you are also participating in this trial. So it's a multi-cohort trial, as you know, and the first results regarding the information obinutuzumab plus bendamustine were presented by Stefan Stilgenbauer at the last ASH meeting. And you know that there's a stratification for the analysis between the fit, so-called fit patients and the so-called unfit patients with respect to SEER score and kidney function. And I picked now the bendamustine obinutuzumab treated patients in frontline, 158 patients as a whole. And you can see here the patient characteristics. There is a quite high number of patients in BNA stage A. I'm always wondering, especially when I'm looking on the US trials, about the high percentage of patients in formerly early stage CLL. In Europe, the trend is not to treat a patient in BNA stage A, which corresponds to RISE stage 0, 1, perhaps some RISE stage 2. But anyhow, we have to analyze this. But on the other side, it's approximately 1/3 of the patients in an advanced stage, that is BNA stage C. So there's a great variety and heterogeneity when looking on the biological profile of the CLL. There are some patients with 70p deletion, other cytogenetic abnormalities. We had 2/3 of the patients with an unmutated EGHV status, and this corresponded nicely to the percentage of patients with a sub-70 positivity and CD38 positivity. So when looking on the response rates, you see the overall response 78.5%. At the first look, perhaps a little bit disappointing when keeping in mind these more than 90% with BR in the fit patient population, as it is mirrored in the CLL10 trial. But here is a mixture of fit and unfit patients. So you see that the unfit patients had a not so pronounced overall remission rate than the fit ones, although with 81%, well, it could be questioned why it's not reaching the 90 as it was communicated with CLL10. However, a quite considerable rate of complete response with obinutuzumab plus bendamustine, and only one single patient out of these 158 was progressive while on treatment. So we can summarize at this moment, I think the trial is still going on, that the combination with obinutuzumab and bendamustine appeared to be generally well tolerated. There were no unexpected toxicities. The CR rates are quite promising. And perhaps then obinutuzumab plus bendamustine might be an alternative to rituximab plus bendamustine. So I already mentioned these first application infusion-related reactions with obinutuzumab, and I showed you these unexpected side effects with all the new other drugs. This is a slide I love to present many times. You know it also from other German colleagues, I guess. We tried in our study group to stratify fitness and to define fitness status. You know, median age at first diagnosis is 72. All these 4 human beings may be at the age of 72, but it's a broad heterogeneity within the 8th decade of life. Some of them are fit enough for the Olympic Games. Other ones are just sitting at home and need support for daily life. So the go-go, slow-go, go-go terms are questionable, of course, but it's, well, maybe some kind of medical marketing. So beside the question who is in fact in need for treatment, I mentioned the surprisingly high percentage of BNA stage A patients in in some trials. What is the goal, at least? Should we look on progression-free survival, while there is no difference in overall survival? Should we look on complete response, even at a molecular level? Should we address MRD negativity? Or is it, from a patient's point of view, just time to next treatment? So to say, should I live together with my disease and going to die at some time point? Or must I have eradicated my disease to live longer and to die at any time point? And does it help to look at the prognostic and predictive factors, the biological profile in CLL, and to which extent the patient characteristics matters? And this is, of course, the question, what kind of comorbidities are present? And now we had a number of informations from already finalized trials. We had this broad variety of new drugs. And how do these informations now have an impact of my design of future trials? So these are the ingredients of the new trial generation. We had still the classical chemotherapy. We had a new generation of anti-CD20 antibodies. That is currently obinutuzumab. There is also broad use of ofatumumab, especially in the United Kingdom. While I would say the broad majority, at least in Central Europe, is still with rituximab. And we have the tyrosine kinase inhibitors, the PI3K inhibitor, and in the near future to come, the BCL2 inhibitor. So how to bring these new drugs in first line, and how do they compare to the so-called standard of care? So the first step was presented also at last ASH. That was the randomized trial Ibrutinib versus Chlorambucil in the so-called older patients above the age of 65. So it's a typical patient population included in this trial, considered not to be fit enough for a fludarabine-based regimen, and therefore Chlorambucil was thought to be standard of care. and was the comparator. The median age was 73. There was a 70p deleted CLL excluded, of course, because of the randomization into Chlorambucil, and standard dose Ibrutinib versus, well, some kind of standard dose Chlorambucil. There is a variety of doses in Chlorambucil. I think there is no internationally consensus really accepted for Chlorambucil. I know that our English colleagues are using much higher doses of Chlorambucil, while this is a German type Chlorambucil dosing, so to say. Interestingly, it was not only the prolongation of progression-free survival in this trial, but it was a prolongation of overall survival in favor to Ibrutinib over Chlorambucil. And this was seen, although there is only a very small proportion of patients achieving a complete response with Ibrutinib. So this makes the achievement of a complete response or even MRD negativity questionable when looking on the ultimate goal, and that is overall survival. So this trial asks the question, do we really need a complete response? Interesting finding. So we can now conclude that based on the CLL11 trial and this RESONATE trial, there is, I think, no reason anymore to handle Chlorambucil as a comparator for future trials and to use Chlorambucil as a monotherapy with some, of course, particular clinical exceptions like the really very old patient or the patient with frailty. And based on the CLL10 trial, I would say BR can be considered a backbone for patients above the age of 65 with an appropriate fitness. It's not only reserved for the very, very fit patient, it's also, as the MaBLe trial has shown, an option for the less fit patient. And maybe BR, or in the future, based on the green trial data, B plus another anti-CD20 principle, may be one of the comparator to assess the new drugs like the TK inhibitors or other inhibitors to come. So currently in Germany, we are looking at this strategy. We, upon the discretion of the treating physician, we offer a debulking phase for the CLL patient with conventional chemotherapy, mild chemotherapy, for example, fludarabine single drug or bendamustine single drug, then the implementation of one of the new drugs like Ibrutinib, Idela, or whatsoever. And what is under debate, is there a place for some kind of maintenance? I mean, Ibrutinib as well as Idela are thought to be given until progress of the disease. But perhaps there are other drugs for maintenance. We had a trial, as you know, with lenalidomide for maintenance, but this trial must be closed prematurely because lack of sufficient recruitment. But there may be other drugs to come, and the question of maintenance is under debate. We already can see and observe an immediate effect due to the advent of all these new drugs, and that is the number of patients with an allogeneic transplant in the European registry. These are mainly patients with a 70p deletion or with an early relapse after FCR-based treatment. And with the advent of Idela and Ibrutinib, the number declined rapidly and dramatically. Perhaps, however, as longer we are treating patients with Ibrutinib or Idela or whatsoever, there might be the emergence of resistant disease. And then for young patients with a 70p deletion, I think allogeneic transplant must be an option also in the future. And perhaps the numbers will rise within the next couple of years. So this is not the subway figure of the city of Tokyo. It's it's a lymphocyte. It's just a lymphocyte. Very interesting. And you can see here that there are many, many, many options for the invention of new drugs and to interact with a malignant cell. So there's a lot of work to do. And at this point, I want to stop, and I thank you for your attendance. And I'm happy to receive your questions. Thank you so much.